Succes veterinær praksis, podcast nummer 165. Hej og velkommen til, dyrlæge Søren Pejstrup her. Dagens emne har jeg haft på ønskesedlen i lang tid. Vi skal nemlig snakke om præ-anæstetisk testning, mest om blodprøven, men vi kommer også andre tests omkring. Og det kommer sig egentlig af mails, jeg har fået af jer, der lytter til podcasten her. Det blev foreslået for efterhånden længe siden på en e-mail til mig, og siden da har flere af jer skrevet, at det var et emne, I gerne vil have, vi tog op her i podcasten. Så det gør vi så i dag. Og lad det samtidig være en opfordring, hvis du sidder med en idé til et emne, den her podcast kunne bruges til, så skriv til mig. Hvis ikke du har min e-mailadresse, så kan du tilmelde dig nyhedsbrevet over på hjemmesiden, og så kan du bare svare på en af de mails, du har der. Du kan også kigge tilbage i kartoteket, for jeg har sendt nogle stykker efterhånden igennem årene, så det kan være, at du har en liggende fra mig. Jeg hører i hvert fald gerne fra dig. Og når vi nu er ved det, så hvis du gerne vil have nogle faglige opdateringer, tips og tricks og protokoller og den slags, så vil jeg klart anbefale dig at prøve at tilmelde dig nyhedsbrevet over på hjemmesiden. Og det er ikke sådan, jeg sådan spammer en hel masse, og hvis ikke det alligevel indeholder noget, du kan bruge til noget, så kan du bare melde fra med et klik. Jeg synes, du skulle prøve at give det et skud. Du kan gøre det i bunden af dagens artikel, der hører til dagens episode. Den finder du som altid sammen med episodens nummer. Så i dag er det på SIVP.dk/165, SIVP.dk/165, og så over til interviewet med Hilarie.
Hi, Hilarie, and welcome to the podcast.
Thank you.
And thank you for taking the time out to talk to us. We dive right in, but just before that, what is important that people know before we get into the topic? What is important that people know about you before we get into the topic?
Well, I think two things. One is we're speaking English because I am American. I live in Uppsala, Sweden now, but as a veterinarian, I practiced in the US for about 11 years. So all of my experience was gained there, but for the last 2 years, I've been doing laboratory diagnostic education here in the Nordics.
And you work for IDEXX as well, right?
Yes.
Yeah, we have to put that in just for a disclaimer, because we are going to talk about blood samples, and you, of course, have a vested interest in us doing more blood sample, of course, but we will also, of course, talk about, that is going to be one of my questions anyway, what is necessary and what is, can we live without?
Yes.
So pre-anesthetic testing is fairly new to me, or at least within the last 10 or 15 years. We did blood samples at uni when I was at school, but pre-anesthetic testing was sort of something that you only did in university. Out in real life here in Denmark, it wasn't practiced as much. So, and I usually start with a story about a bad patient I have, and people must think I'm a very bad veterinarian. Hopefully I'm getting better every day. But I had a patient at one time, an older dog that was in for something simple, I guess, dental work or something. I don't really remember. It's quite a long time ago, but it was an older dog, so we ran a blood sample. And there was just a slight increase in creatinine. And the owner, of course, asked me, "Is that important?" And I didn't know. Of course, I now know that is a failure on my part, but I didn't recognize it as important. So we anesthetized the patient, did the surgery, and everything was fine. And the anesthesia was without any problems that I found. And then a day or two later, the patient crashed. And it wasn't eating, it was vomiting, and it was doing very poorly. And we had to take it in, and we have to have it on fluids for like 2 days. And I didn't charge other than the medicine I used for it, even though we've been using it. We've been using 2 full working days, and the nurses and me and another veterinarian was on this patient. And everything ended up being okay, I guess. But it was a very bad experience. So the next time I had one that had a slight increase in LAT, liver enzyme, I was like, I'm not going to do that. Find another vet. It's not going to be me. So now my question.
Oh no.
So now my question is, what is important and what is not important?
This is a good question because, you don't think something's important until it is very abnormal. So you run pre-anesthetic testing. If everything comes back within normal limits, you think, oh, maybe it wasn't important to do this. But then in that situation and in others that I've seen, it's when it goes bad that you really wish you had done it. So it's a complex topic, and I think there's a couple of different ways to approach it. So one reason to do pre-anesthetic testing, like you mentioned, is to identify pre-existing conditions that could increase the risk of anesthesia. And when you look at the research, in human medicine, it has been proven that pre-anesthetic testing actually doesn't increase the chances that you'll find that sort of thing. So they don't recommend pre-anesthetic testing for human subjects. But when you look at the research in veterinary patients, we find that the percent of cases where you can identify a disease that you didn't previously expect is high enough that there is good evidence to support the recommendation. We don't really know why. Why is it so different in humans and animals? We think part of it is because our patient history is always secondhand. They can't actually tell us, which we know, especially our cat patients. We know that they can hide their illness. And when you look at the research, you see a higher percent in cat patients than in dogs for that reason. But when you think about pre-anesthetic testing, for me, identifying a severe subclinical disease is not really what I'm expecting to find. You would expect a good case history and physical exam to give you that. And some of the research has shown that adding diagnostic testing doesn't always increase the chance that you'll find something like that. But what I do like pre-anesthetic testing for is it may not be the decision between, yes, I will do anesthesia or not, but it can help inform my anesthetic protocol. So if I see something like that, let's say it's just a mild increase in creatinine from the previous year. So let's say last year this dog's creatinine was 79, and this year it's 100. Now, according to IRIS guidelines, an increase in creatinine within reference interval, that is consistent with CKD. I mean, if I could confirm that that was persistent, I could diagnose that dog with CKD. But that's not going to prevent me from doing something like a dental cleaning because I know the health benefits of that. But now I can use a more kidney-safe protocol. I can start them on IV fluid therapy about an hour before induction, and then continue IV fluid therapy post-op and just really improve renal perfusion and just make that safer for the patient. So I think there's two levels. There's the level of, this is a 12-year-old cat and I've never done blood work on it. Before I do a elective procedure, maybe it's a good idea just to run a basic profile. But if it's a younger patient or if it's a patient that I've done blood work on before and I have a good baseline, there is still benefit to doing that recheck when they arrive for surgery. They're already fasted. It's kind of the perfect time because if I can do anything to make my anesthetic event safer, I want to give that option to the owner.
So I had this patient that crashed a couple of days after the anesthesia. I want to go through some of the values in a more structured order, but just for the fun of it, let's start with the case there, because I wasn't really considering what a safe anesthesia is I was in the sense that I have the patient in the house today, and the next 2 hours is going to be my main focus of getting this patient out the door. As soon as it's out the door, it's not my problem anymore. And this anesthesia was safe enough, and the patient is still living. But 2 days later, it might not be. So a safe anesthesia is also more than just getting the heart to beat the 2 hours it's under, right?
Yeah. Exactly. And I mean, even if it's an emergency, so I talk about this when I'm talking about pre-anesthetic testing, because people are like, oh, if it's an emergency C-section, dystocia, we're going to do surgery. Why would we do blood work first? Well, for me, in my clinic, we have one person prepping mom. We have one person running the blood work because I want to know, what's her calcium? Does she already have eclampsia? What are the chances she will survive this surgery? Because if she doesn't survive, do these puppies have someone to feed them? There's a lot of considerations there. And I want to know, if I open up this patient and they start bleeding excessively, what is their platelet count? It's too late to ask that question once I've already put the scalpel to skin. You know what I mean? So to me, regardless of the situation, I like to have that basic, starting line to know, if I'm in surgery and this patient suddenly has an arrhythmia or suddenly starts bleeding or something bad goes wrong, I want to already know what are my differentials for this. And they don't include pre-existing disease that I've already ruled out. So I think that's another benefit.
So we're actually talking about 3 things now. So getting a more... I want to make a list of good arguments, because, of course, hopefully my idea with the talking about my own failures is that hopefully someone can learn from them and not do the same thing. So I want to make a list of good arguments, and I'll try to maybe to press you on some of my counter arguments as well.
Definitely.
But knowing something about if the anesthesia is safe here and now, and then knowing if anesthesia as a general thing is safe for the patient, maybe long term, and then finding underlying disease that we would not otherwise have found, that maybe is not critical to the anesthesia per se, but can be critical to the patient. Maybe low calcium or high infection numbers, or a lot low platelet counts, or
yes.
Is that sort of the 3 main things, or?
I think you could even add a 4th, that this is also kind of an ideal time where we could establish a healthy baseline for this patient. So they're already fasted. They're here for anesthesia. If it's an elective procedure, generally they're pretty healthy. So we have those other benefits already. But even if every single result is completely normal, that's not a waste of resources. That's not a waste of a test. Now we have, what is the healthy baseline for this patient? What's their normal creatinine? What's their normal hematocrit, albumin, ALT? So that 2 years later, if they come in vomiting, I can compare back and see, are there any significant changes?
And another thing, I think, as veterinarians sometimes discard a normal result, and that can be blood samples, but any other test basically. A normal result is just normal, and we don't even tell it to the owner, because otherwise, why should I call the owner and tell them that the blood work is normal? otherwise we wouldn't have done the anesthesia, right? So why should? But the owner is of course asking. So that things are normal is also a finding in itself.
Absolutely. And I mean, I come from a place where almost none of my patients were insured. So all of this was paid by the pet owner. So it was really important to me to show value for what they spent. So if I'm asking them to spend 100, 150 euros for blood testing on top of the surgery, I'm sending them home with a copy. I'm giving them something visually to show them, even if it's completely normal. It's not just me calling them and say, yep, everything's negative. So the owner's like, oh, that's a waste of 150. It's like,
it seems
look at
like
this report. Yeah, like, look, we checked his kidneys. They're functioning really well. The liver is functioning really well. He had plenty of platelets for clotting. These tests, the value of them is that not only does it tell me that he's as healthy on the inside as he appears on the outside, but now I know what's normal for your dog. So if we ever need to do blood testing again, and that actually helps bond the customer to your practice as well. I would have clients coming in because, my doctor knows my dog. She knows what's normal for my dog. And that's true if you have the data to support it. So,
yeah, that is actually a really good point. That I don't. It's not that I just know the pet and I know the owner. I actually really know the pet because I know something about the pet others don't.
Exactly.
Yeah. But then how about all the patients I've anesthetized for like 10 or 12 years of my career now, and I've only done pre-anesthetic testing on maybe not even half of them. How about the other half that went well and nobody? Of course, I get that I might have found a benefit in having a baseline when that patient was vomiting. I get that. But in regards to the anesthesia, how about all the patients that I do anesthetize now that are doing fine?
This is another thing that I think is worth sort of considering, because let's say you did have a patient with a mild underlying renal or liver disease, which are the most common things you would find. You wouldn't really expect them to acutely die or crash like your patient from an anesthetic event. But you could be causing further damage. You just may not see it for 2 years. And I would talk about that when I had customers asking me about pricing too. Mm-hmm. They would say, at your clinic, it costs, who knows, 300 euros to do this procedure. I called the clinic down the road, they charge 50. And I would say, well, just make sure you're comparing apples to apples, as we say in the US. Like, what's included in that? Because I saw patients in my hospital. I had a cat that was 7 years old, previously completely healthy. The owners decided to do a dental cleaning. Took him down the road to a less expensive clinic. They did no blood work. They did no IV catheter, no IV fluids. They used, I think, ACE promazine only, and then Metacam injection as a follow-up. So basically no analgesia at all during the procedure. And that Metacam injection sub-Q is really not going to kick in for at least 12 hours. So your cat was in pain. Your cat did not have blood pressure monitoring. I can be pretty sure this cat probably did have an acute hypotensive crisis and acute kidney injury, because 2 years later he came to me in complete failure. Yeah. And I'm like, I can't tell the owner that. Of course, I wouldn't tell the owner that. But looking at his history, I'm like, wow, no wonder this beautiful 7-year-old cat is now dying of kidney disease. But the vet that charged $50 is never going to know that.
No.
So that's the worst case scenario. I'm not saying every patient you don't test is going to end up that way. But I think it's also valuable to realize just because your pets live through your anesthetic doesn't mean it's ideal for that patient.
But that is sort of what I'm getting at, Egos. And I'm trying to to find how big how broad the topic is here, because I'm trying to get a sense for how important this really is.
Yeah, I mean, when you look at the research, you're going to find a significant abnormality in about 10% of patients. If you test every single patient you put under anesthesia, healthy, senior, whatever. When you look specifically at certain populations, like there's a smaller study, I think it's about 100 dogs that presented to one clinic. The senior dogs, about 30% of them had something abnormal. So it depends on what you test, who you test, and when. But there is value in it, even if the test is completely normal. So if you have the ability to change your anesthetic protocol in response to what you find, I think it's valuable. If you only do one type of anesthesia and you don't do fluids and you don't do monitoring blood pressure or anything, I don't know if there's value in doing it, because what's it going to change? I always say, if a test is not going to change how you treat the patient, don't do the test.
Yeah.
So I think there's a couple of levels that need to be recognized. I mean, when I talk to vets about deciding what kind of profile should they do for pre-anesthetic testing, one thing that often comes up is electrolytes. And I say, the chances that you'll find a significant electrolyte abnormality in a pet that appears healthy is really unlikely. Addison's disease might be the one exception to that.
Yeah.
But if you have a choice of different fluid therapies, if you have the option of supplementing your fluids with additional electrolytes to improve their electrolyte profile while they're under anesthesia, they'll wake up feeling so much better. But if that is beyond the level of where you're at right now, don't do it. It's not gonna change how you treat the patient. So I think sometimes I usually recommend start small if this is something you've never done. And then as you become more aware of, whoa, I'm kind of finding a lot of things here, then you might want to take the next step.
Yeah. And when you say start small, when you look at the submission form for IDEXX, it's a fairly large profile for anesthesia as well. Not as big as a large checkup, but still a fairly decent number of values we get from that. But what do you mean by start small? So, how little is enough, or how little can I get by with?
So I also think about this in terms of my goals. So I want to make the anesthesia safe. I want to make sure this patient can heal. And I want to do, and I ideally also would want to test those parameters that are helpful to monitor over time. So the list is a little bit larger in a cat than in a dog. I sometimes start with the AHA canine life stage recommendations. So they say a combination of hematology, chemistry, and urine is ideal. In most clinics, the urine is going to be a tough one because most clinics are not used to including urine in a pre-anesthetic profile. So if that is too much, I say, let's leave that out for now. But having urine is so valuable, and it makes interpretation of the chemistry easier. So, but if you want to start small, I would say we at least need to know a hematology and a 10-panel chemistry. So we're talking about glucose, we're talking about a small liver panel, which would be usually alkaline phosphatase, ALT. I want some kind of measurement of GFR, whether that's creatinine, SDMA, urea. And then we need to know about proteins, so globulins, albumin, just to make sure that those are the most critical things. In my clinic, the test range was a little bit wider. It looked a lot more like the recommended IDEXX. So we would actually offer two options. We would say we have the hematology and the small panel chemistry. That is our minimum. In my clinic, actually, we would not do anesthesia without pre-anesthetic testing, but that's a different story. And then I had a larger profile, which was the more advanced chemistry. So it was a 17-panel chemistry, the full hematology, a full urinalysis, and we would do coagulation factors. In Denmark, depending on your region, coagulation factors might be a good idea if you haven't tested for angiostrongylis. I talked to one of the clinical pathologists at the university. She says even for dentals, they always do coags just because they've had some bad experiences with angiostrongylis, and even just a tooth extraction, if they happen to be affected and they happen to have developed the coagulopathy, it can be life-threatening. And you don't want to figure that out in surgery. So.
No. We have an in-house IDEXX laboratory at the clinic where I work, and we have the small anesthesia profile with the 10 values in it, and we have 2 or 3 for liver and creatinine and urea for the kidneys, and a total protein. I guess that is basically it, right? And how much would I expect to catch with if I start small with that, or is it so small that it doesn't make a difference? Should I consider doing all this coagulants and urine to be to catch enough to make it worthwhile?
Of course, it depends a little bit on your patient, but if you're talking about a relatively young, healthy patient, you don't see anything abnormal in physical exam, I think a hematology and a Chem 10 is a good starting place. If it's a senior, that's when you really start to see a big difference in how many things you can identify on a larger profile that would make it a lot more relevant. I get nervous if I don't at least have a hematocrit, a total solids, a BUN, and a urine specific gravity. I mean, that is my absolute minimum on it, even in a 6-month-old happy, healthy puppy. But if it can affect your anesthetic plan, it's worth doing.
So I'm thinking we have to be concrete in a bit, but okay. I have one thought I want to get out, because you also said that in the clinic where you worked, you did blood work on all the patients, and it wasn't an option to say no. And for some of my patients, it's not an option as well. So if I have a pyometer, they ask me, how much does it cost to fix my dog? And I give them a price. And I don't talk to them about how much is ultrasound, how much is blood work, is a radiograph involved, how much is anesthesia, how much is pain medicine. It's just a price for the thing, right? And I'm probably not going to stop the surgery unless the blood work is completely off. But I run a complete panel with everything in it, and all the values. And it's not up for debate. It's either or. If you don't want me to treat it, of course I can help you kill the dog, right? But I'm not trying to make a half price. Okay, so we skip the blood work and maybe skip the fluids therapy, and you can get it for half off. That is not an option for my patient.
Right.
So and of course there's a line somewhere there where you have a completely healthy puppy that is going in for a tooth extraction from one of the puppy teeth, right? So, but there's something in your being a vet and deciding what is best for your patient, and doing dental work in my clinic just costs this, and I don't discuss if there's radiographs and there's blood sample and anything. So it's also something about how we see ourselves, or what level you see yourself at, or how we talk to the owners about this.
Exactly. Yeah,
I don't know that there wasn't a question in there. That was maybe a thought, but maybe you can comment on what you think about that.
Yeah, I mean, that can be a difference between clinics. So if a customer called my clinic and asked how much a tooth extraction was, my price includes the blood work at a minimum. But if they call someone else, it might not. So that is also a difference. And I have worked in clinics where the blood testing was optional, and it did scare me. But that also kind of leaves customers with a bad feeling of, you told them how much the price was for the procedure, they came in, and then you also told them about this added charge that's optional. Mm-hmm. So it's really important to make sure that pet owner knows in advance before they come in for surgery, if this is something you recommend. But yeah, I agree with you. There are some standards of care that are not optional. But unfortunately, that's different from vet to vet. So there are vets that still do dental clings without endotracheal intubation. There are, vets that still do major anesthetic procedures without an IV catheter, without IV fluids, without monitoring blood pressure or even EKG. All they get is a pulse ox. So it kind of depends on what is the standard of care for you. For me, even if it's an emergency pyometra, I'm still doing blood work. I want to know, is her immune system still functioning? Is she in DIC? Is she in systemic organ failure? But also, does she also have pyelonephritis? That's something I want to know, because it is going to change how I treat her, both in the OR and afterwards, more importantly afterwards. So I think it's something that every vet has to sort of develop as they continue practicing, is what is the minimum standard for me? And do my clients expect more than where am I going to refer them?
Yeah. The reason I think this is important is because I know from personal experience that one of the reasons that my patients are not recommended blood work is because of my own level or my own thought process about my level. So, and it maybe comes down to self-confidence. I don't know, but if I have to be honest, I have to also to look inwards. It's not always the owners that wants the cheapest option. It's also me as a vet sometimes.
Yes, I would agree with that. And I hear that a lot, that intense fear that we as veterinarians have of recommending something that is more expensive. And, logically, we know that's not our job. We're not their bankers. We're not their financial advisors. Our purpose is to recommend what is best medicine for your patient. But the reality is, veterinary medicine is expensive. And most veterinarians are very frugal people. Yeah. We are very sensitive to price. And it's something that we have to really struggle with and think about and decide for ourselves. How can we provide the best medical recommendation, but also let the pet owner know that the economy is also really important to us, and we know it's important to them, and we care about it, because that's the truth. So offering more than one option sometimes is a way where you can say, here is my official recommendation. This is best level care. But there is this other option that's a little less expensive. So that is something we can do. But especially when you're thinking about pre-anesthetic, it's funny how few pet owners actually give that argument. So we have a clinic here, actually in Denmark, that recently started offering pre-anesthetic testing to all their patients. And this was new. And I think more than 60% of them, the pet owners were like, yeah, sure. I mean, and if we look at studies, even just looking at how many clients actually leave the vet clinic when prices are increased, on average, it's about 3% of clients, and they are usually the 3% lowest revenue clients. Your best clients they will pay for your services. They care about their patients. They trust your recommendation. So if you truly believe it is the best medicine, the pet owners will comply. I mean, they know, I mean, hopefully most of them know nobody ever got rich as a veterinarian.
Not in money anyway.
Yeah, that's not what we're going for. But yeah, that is something that's really hard to overcome, is the fear of recommending something that you don't fully believe in if you're new to pre-anesthetic testing.
Yeah.
Until you see those first 10 cases where you're like, oh, wow,
Yeah.
I'm so glad we didn't do this anesthesia. Then it can be hard.
Yeah. But that is a very important point, that I actually myself as a vet do believe that this is the best care, that I'm not just doing the blood work because you told me to, or because IDEXX told me to, or because my boss told me to, or so I need to myself believe that this is the right thing, the right professional thing to do.
Absolutely.
So maybe we should be... Oh, sorry, you were going to say something.
Well, I was just going to say one easy way to convince yourself, and also everyone that works as a team in the clinic, the nurses, the people that work in the laboratory, if they have to talk to pet owners about blood testing, they might be uncomfortable too. So I always recommend, if this is something you're going to start doing in your clinic, start by just testing all of your own pets. Your nurses' pets, your vets' pets. You will find significant changes and you'll be like, oh,
Yeah.
This is why it's a good idea to do diagnostics, even if we don't suspect severe disease, because this dog has severe blood in its urine. This cat has a lot of crystals in her urine, or this dog over here has mild kidney disease, and we didn't know. And imagine if we had put them under anesthesia without knowing. So if you need to convince someone in your team, tell them to test their pets.
Yeah, good. So if the answer couldn't be that we wanted to do all blood work and all urine samples on every patient, and maybe we can talk about more nuances in that, then we have, I guess, sort of like three categories of patients, or maybe four. We have the young puppy, or the young kitten. We have an adult, and we have a senior without any clinical signs, and then we have the acute pyometra disc C-section, or all the critical ill patients with the severe clinical signs. So we sort of covered that one. But if we take all the appear to be normal patients in the three categories, what would an ideal situation for pre-anesthetic testing be?
Let me start with the young puppies and kittens. So this is another thing we haven't really talked about, but if it's a small body size patient or a very young patient, then I have to balance the value of the pre-anesthetic testing with the risk of taking more blood out of this little animal. So if it's a truly juvenile patient, my biggest concerns are blood sugar and the possibility of a hereditary condition like a liver shunt. So I'm actually really conservative in very young patients. Sometimes I will just do a little tiny microhematocrit tube, measure a hematocrit total solids off that, and use a glucometer to check the blood sugar, and keep checking the blood sugar throughout the procedure to see if you need to supplement, and a urine-specific gravity. If I can get an extra drop, I'll also do a blood smear, make sure my platelets look good, That's for patients maybe under 5 kilos. You have to be really careful about not causing an anemia by drawing all these blood samples. And then if we're thinking more of a young adult healthy, hematology, Chem 10, you're way above and beyond the typical standard of care. If it was possible and you could add a urinalysis, you'll be surprised how many patients only have significant disease on urinalysis. So that's kind of two levels there. And then when you're talking about a senior with no symptoms, that's when I like to have a little bit of a larger chemistry. So if you're using in-house equipment, I want to IDEXX, if you're talking IDEXX things, I want at least a Chem 15 because I want to see that calcium and phosphorus. I want to see the GGT cholesterol. There's so many common diseases that seniors get that you can only pick up with those. But everything else the same, hematology. And then if you really want to increase your standard of care, urinalysis, a complete urinalysis, not just a urine-specific gravity. So the chemical and the sediment.
Mm-hmm. Is that also for the senior patient?
Yes.
The urine sample, of course, but also the large panel.
Yes.
Yes.
I need the larger panel in seniors. And then whether or not you include electrolytes, it depends on if you will do something about it.
Yeah.
If it's not completely normal. And again, with electrolytes, just within reference range doesn't mean normal. So you also have to really practice with interpreting those.
Yeah. And how about when and why, not why, but when to draw the sample? So if I have to submit them to IDEXX, I would have to draw the blood 2 days before scheduled surgery. And I know ideally I have to draw the blood on the morning that the patient is going under anesthesia, but sometimes the boss would like to start 5 minutes to 8, not 5 minutes past 8, right? So,
Yes.
So the blood sample actually needs to be run 2 minutes ago. So he would like it to be run the day before at least, or maybe if I see a patient for vaccination booster shot and I recommend dental work there, I draw the blood on that day so we have it next week when it comes back in. Is that okay, or how much time do we have here? What can I expect?
So there's not a lot of great research on this. If you ask a clinical pathologist, they say same day, which obviously, the things that are going to change the most are your hematology and electrolytes. They change every couple of minutes, When you're talking about things like renal and liver tests, really it takes a couple of weeks for them to change. So if it was a young, healthy patient in my practice, I would go up to 6 weeks. That's not based on anything. That's mostly just for owner convenience. And at least I knew 6 weeks ago everything was okay. But if you want to use a little more scientific approach, if you're looking at the serum half-life of most of these parameters, 2 weeks would really be kind of the better option. And then, of course, if anything changes in their health status during that period, then you're really sort of risking the same thing. It's almost like you didn't even do the blood work. If they suddenly start vomiting or suddenly start urinating more or stop eating on their own, then we need to have that discussion with the pet owner about possibly doing it again.
And in my experience, when a sample is less than 6 months old, it's getting more and more difficult for owners get the owners to agree. So when it's older than 6, maybe 12 months old, most owners will agree to do another or just maybe a reduced size blood sample. But when it's less than 6 months old, it's getting very difficult for me anyway. What would you say to that? Is 4 months okay? 6 months okay? Maybe it's a difficult question if there's no research backing it up, but what's your gut feeling?
For an adult, I would feel comfortable. For a senior, 6 months can be 15 years in human years, so if it's a cat and it's 13 years old, I'm going to say 6 months is way too long. But if it's a 5-year-old dog, I'm going to be like, you know what? Let's go for it. And of course, recommend to the pet owner. It would be ideal to repeat this, but 6 months ago it looked great. So here's how much it costs. My recommendation is to do it, but I also feel confident proceeding without. So, but more than 6 months, I agree with you. I don't know if you're if you're getting the most benefit out of it at that point.
Yeah. Good. So then we have to talk about findings, and I'll let you go from after that. But we sort of, you touched about on this with the electrolytes and the glucose. We have to do something with the fluid therapy during the surgery. And I have my case with the creatinine, where that should have been a hard stop. Don't put this under unless you really have to. So there is a gray zone area as well, isn't there, where we find a significant finding, but it's not going to impact the anesthesia so much. So I do a lot of dental work, and I from time to time see the ALT elevated, and of course it has an abscess and 70 bad teeth, and maybe it has fever and it's nervous and I haven't been eating and all that. So maybe you can talk about how to approach if there is something in the blood work.
This is the next level. And there are some guidelines that you can find that have, green light, yellow light, red light recommendations. Most of those are corporate documents from corporate animal hospitals. But they're useful to kind of make you think about it. But like you said, if the patient actually does have a significant disease, you're not going to be surprised to find some abnormalities in that blood work. But what are you going to change as a result? So in that example, slightly high ALT. Okay, so I know liver cells are being damaged. They're leaking or they're rupturing. What am I thinking? Could there be bacterial showering from this horrible mouth? Absolutely. Maybe I want to think about doing a little bacterial culture and taking a look at that white blood cell count and see if maybe this is a patient that actually does need antibiotics. Because if those bacteria are in the bloodstream, they're also in the heart valves. They're also in the kidneys. But not every slight increase in alk phos is going to make me stop my procedure, obviously. ALT is a little bit scarier. Any increase in a cat, and I would at least pause and think, what can I do to make this safer? What are my drugs that I'm planning to use? Can I switch something out that's a little bit more gentle to the liver or that's not metabolized by the liver? Particularly if you're thinking about NSAIDs or something like that to go home with. If I see slightly high ALT, have I thought about testing for pancreatitis? Because I need this patient to eat after surgery. So unfortunately, there's not an easy answer. It's patient specific and it's result specific. Some values are easy. If it's high, it's a problem. But some values, like creatinine, if it's a greyhound, it's going to have a high creatinine anyway. How high is too high? It's very breed specific, and so, but I wouldn't do the test if you're not comfortable with how it would change how you would treat them. So if seeing a high urea is meaningless to you, don't test it. But if seeing a high urea is a trigger for you to think, oh, there might be upper GI bleeding in this patient, which is true, maybe I want to think about sending them home with a gastroprotectant, or maybe I don't want to use meloxicam in this animal. So, yeah, that's the next hurdle is, okay, now that I'm testing, how do I know what to do with this? Especially if it's just a mild increase and it could be something or it could be nothing. In those situations, look at your drug protocol, look at your fluid therapy protocol. What can you do to make it better? Talk to the pet owner and say, there is some mild changes. I feel confident it's not going to affect the safety of our anesthesia. Here's the different things I'm going to do to make it safer. But I do recommend rechecking this, because if it continues to increase, then we might want to take the next step. And I would say it's about 50-50 in my clinic. Half my pet owners were like, I just want you to do the dental and let's see what happens. And the other half were like, well, let's postpone, recheck it in 2 weeks, see what happens. Some of them got better, some of them didn't. So, It doesn't always mean you have to stop the surgery. I have a lot of surgeons that are like, I don't want to do pre-anesthetic testing because I don't want to have to reschedule my surgeries. And I'm like, oh God.
I have to be honest. It is an argument
it is.
to make the day flow naturally and the money flow as well. But it's of course not a valid argument when we're talking about as two veterinarians, and I'm only employed. I don't own anything in the clinic, so I don't really care. My main concern is my patient, and that of course that is the only concern that. Sorry, that was a tangent, but it is something that is talked about.
Yeah. But not every number that's in red means you have to stop. I think that's something that's the next level is really thinking hard about what actually affects the safety of anesthesia and what am I going to do about it?
Yeah.
Because it's not doing the surgery isn't always the option. If the patient has dental disease, that is also a severe, life-limiting, health-impacting condition that we can fix.
Yeah.
So it's a balance.
But I do have the option to give it antibiotics for 10 days and reschedule it. And even for some of the worst cases, I can give them maybe not meloxicam, but something else then. But try to help them for a short while. Mm-hmm. And you mentioned pancreas. If I find, how about amylase and ALT? Is that a hard stop for otherwise healthy or almost healthy patient?
ALT, if it's increased at all in a cat, I want to know why. It may not be a hard stop if it's only mild, but I want to take a closer look and see if I can figure out what it is. Pancreatic testing would be my first choice. If it's a dog, I need to see a little bit higher increase for me to actually stop. But beware that ALT doesn't have a very long serum half-life. So if it's high, it's telling you this is a recent thing. It's not like this has been here forever. So especially seniors, I'm pretty much reaching for that pancreatic test right away. The pancreatic specific lipase is much more sensitive and specific than amylase and lipase. So if you have the option to run an FPL or CPL, those are preferred. But a lot of profiles include amylase and lipase. If they're high, especially lipase, especially if it's higher than it used to be in this dog, that is also a reason I'm going to do a pancreatic test. Because pancreatitis is notoriously underdiagnosed and it has huge implications, especially with anesthesia, because I need them to not be nauseated and to start eating when they go home. So, but that wouldn't prevent me from doing the procedure either. Even if I diagnose pancreatitis, okay, I know this patient's going to need a little bit of a heavier analgesia than I might have planned, and I'm going to add on some antiemetics, simple things.
Yeah. How about blood infection numbers in an otherwise healthy patient, or maybe a low or lower blood count?
That would be tougher. I expect to see a stress cortisol leukogram, maybe some mild inflammation in a pet that has maybe dental disease. If I saw obvious inflammatory leukogram in a pet that was there for a elective spay or something, that would make me take a step back. I don't want to do an elective procedure in a pet with an ongoing infection. My first look is always urine, because it's usually where it is. I definitely don't want to do a spay in a dog that has a raging urinary tract infection. So white blood cells, that would make me stop and think. Especially, like you said, if they are low, I need this pet to heal if I'm going to do this. So I need to figure out what's going on first.
So you mentioned healing, and we talked about bleeding, and now kidneys and livers and maybe pancreas. What else? How about the heart? Anyway, you have these heart markers there, the proBNP. Of course, I will examine the patient and listen to it and give it a thorough clinical evaluation, of course. And these special markers, the SDMA, the proBNP, other the heartworm testing. Is there anything else, any other organ that we have to consider here?
Well, I'm glad you mentioned the heart, because I think it is good to say that blood testing is not the only diagnostic test you may want to consider before anesthesia. It is standard practice now, especially in areas like the US, to also do an EKG pre-op. We did that in vet school, and a lot of clinics are now offering that as standard of care, and they will not do anesthesia without a pre-op EKG. And that has saved me a couple of times. I've had some, dilated cardiomyopathy that I couldn't hear and wasn't suspecting, and picked it up on that pre-op. And thank God I picked it up on the pre-op and not intra-op. But in particular with proBNP, I think the big benefit there is older cats. So it's not a test that is recommended as a screening tool for all cats. It's recommended for cats that have risk for cardiac disease. So a normal, young, healthy house cat, very unlikely. The older they get, the more risky. So we see increase in prevalence of hypertrophic cardiomyopathy with age. Certain breeds, I'm going to consider it, especially males. Males tend to be higher risk because they don't have murmurs. Their pulse feels normal. Often it's the silent killer. So senior cats, actually that clinic I told you about that just started doing pre-anesthetic testing, they also did the proBNP testing on all the cats. And they found like 30% of the cats they were going to put under anesthesia had a moderate or severe increase in proBNP, indicating actually that there is stress on this heart muscle. Sometimes that prevented the procedure. Sometimes they went ahead with the procedure anyway, but it is good for the owner to know that before surgery. And the tough thing with proBNP is if it's high, it doesn't tell you what the disease is. It just tells you the heart's under stress. So really, if anesthetic safety is what you're going for, the next step would be cardiac evaluation and echocardiogram. Now you're talking a lot of money from the pet owner, but again, it's a matter of safety. So,
but we're not doing
recommend.
Yeah, but you're not doing these tests basically to diagnose anything. So we are going to all this testing is done for increasing the safety of this for the patient during and after. So of course, if we find anything, we would have to, as you say, do a recheck or maybe do some more specific testing, and then go in a completely different direction. And the surgeon will be very sad because then his surgical patient ends up being a medical one, and then an internal medicine patient, and he loses something to cut to pieces. But yeah, that's always an ongoing debate.
Yep. And I'm going through that with my dog right now. She's 15. She has low-grade chronic renal disease. She has chronic pancreatitis, but she's been really stable for 6 months. And now I'm at the point where I'm like, we really do need to do the dental because that's going to give her more years than anything else, since everything else is stable. But I have to get that echocardiogram first. I just can't do it without it. And I want my owners to have that same option. I want them to have the choice. If they say no, fine, but they should be aware and informed. That's our job.
Yeah.
And you mentioned SDMA. I can talk a little bit about that. Pre-anesthetic testing is one of those things where SDMA can be really helpful. The one way that it can give you information over and above what we can get from creatinine is that it's just an earlier marker. So it can alert you that there might be early loss in GFR before the creatinine increases. So that's the benefit of using it in pets where you don't already suspect renal disease. That's kind of the best use of SDMA. If you have a super dehydrated cat with ammonia breath, your SDMA is probably not going to give you a lot more information than you can get from creatinine. But if you have a dog that appears healthy, but has lost 40% of its GFR in the last 3 months, SDMA is the only thing that can tell you that in your basic panel. So I include it in my pre-anesthetics. I actually found a couple of scary cases in dogs. So this was back when SDMA was first introduced, and I was in practice, and we used IDEXX, and they just added it to our profiles for free. They just included it in the profiles. And I found some crazy high SDMA in young dogs that I thought were healthy. Some of them ended up having hereditary, like polycystic kidney disease and hereditary tubulointerstitial disease and all kinds of stuff that I absolutely would not have found otherwise. So I like including it for that reason in your preventative panels, like a pre-anesthetic. I think it can give you a lot more information. Again, it's a really early marker. It's probably not going to prevent the procedure, but good for you to know, okay, maybe this isn't a dexdomator situation. Maybe I need to think about alternatives.
So we touched on quite a lot of different things here. Did I forget to ask anything important? Is there anything else, Hilarie, you think that we should have included?
I think for a general practitioner, we've pretty much covered it. Nothing replaces a good comprehensive physical exam. But the blood work can definitely help.
Yeah, but of course we have a clinical evaluation, and you would have that type of patient where I would say I have some patients where I say I'm not, even though this is very basic procedure, I'm not going to do that unless we have a blood sample, and just from my clinical gut feeling, I don't know what's up with this dog, but I just get something is wrong with this patient, and I at least want to see a clean blood work before we go ahead. And I would tell owners that, but usually they would have a sense that something is going on as well, and they will agree to that. And that is sort of the clinical evaluation, is that even though even before it comes in, this is an internal case, internal medicine case, more than a dental or a surgical case. So you would have a sense, but this is it becomes more complicated when we're talking about otherwise healthy animals. Yeah.
I mean, you don't want that really bad recovery from anesthesia or really prolonged recovery from anesthesia be the thing that makes you want to do blood work. By then it's too late. Those are the worst cases I get called about. Is this dog had a dental 2 weeks ago, and now his liver values are so high they won't read. Is it because of the anesthesia? Is it because of the drugs he was on? It's like, there's no way for us to know. This could have been pre-existing. Without the test, we have no idea. And that's very sad. It's still sad if it turns out to be some sort of idiosyncratic reaction to clindamycin or something, but it's even worse that we don't know. That's our job. So I agree. Most of them will be normal, and that's good. That's a good thing. It doesn't mean it's not valuable. So I hope this is good food for thought for your listeners.
Before we sign off here, where can people go if they want to learn more about you or pre-anesthetic testing, or what type of services IDEXX provide?
Oh, well, the best place to start is your local IDEXX website. So in Denmark, that's IDEXX.dk. I do webinars twice a month about all types of topics. Sign up for our newsletter. on our website to hear about those. Also, if you want to learn more about pre-anesthetic testing, IDEXX does have a whole library of free archived webinars and education materials on our IDEXX Learning Center. And that's available to everyone. You don't have to be an IDEXX customer. So, and if you are a veterinarian in Denmark, I am your local IDEXX education support. So send me a message if you want to talk more about this. I do education events in clinics. That's my whole job, is to help people get more value out of their partnership with IDEXX.
Well, thank you very much. I've learned a lot here, and I'm very thankful that you would spend a little over an hour with us now. So thank you very much, Hilarie.
Yeah, thank you. Nice to meet you.
Husk, at du kan finde links og noter til dagens afsnit på SIVP.dk, og så episodens nummer, for eksempel SIVP.dk/1. Og føler du et behov for at udvide dine faglige færdigheder, uden at skulle tage en hel dag væk fra familien og fra klinikken, så har jeg nogle online kurser til dig. Du har måske hørt mig sige det før, men du kan få en hel måneds gratis adgang. Og det kan du få med en speciel kode, som jeg ikke deler noget andet sted end her i podcasten. Og det er fordi, at dig, der lytter til podcast, du er noget helt særligt. På SIVP.dk/XYZ får du 4 ugers gratis adgang til kurserne og protokollerne på hjemmesiden. Alle kurserne har specifikke læringsmål, så du ved præcist, hvad du får ud af den tid, du investerer i det. Du kan for eksempel lære at lave en regelret neurologisk undersøgelse og bruge det allerede næste gang, du er på klinikken. Du kan også lære at tolke blodprøver, og du kan lære at lave et godt finlåsaspirat og tolke det sikkert. Der er meget mere, men kig over på SIVP.dk/XYZ og tilmeld dig den gratis adgang, så kan du se, hvad du kan lære og bruge allerede næste gang, du er på klinikken. Udover alt det, så får du også adgang til et lukket online forum, hvor du trygt og sikkert kan dele alle dine i gåseøjne dumme spørgsmål. Dem er der selvfølgelig ikke nogen af. Men vi er sammen om at lære. Du skal ikke lære alene. Vi er sammen om at blive bedre. Og så ved jeg godt, at der er nogen, der er bekymret for at tilmelde sig et medlemskab. De er måske bange for ikke at få det brugt. Og jeg ved godt, at du som lytter til det her, jo går op i din faglige udvikling, for ellers havde du jo ikke lyttet til podcast. Men skulle du nu alligevel være bekymret for at glemme at melde dig fra, når din gratis måned udløber, så skriv lige til mig. Jeg har nemlig resultatgaranti, og det betyder, at hvis ikke du ser resultater i din hverdag, så skal du selvfølgelig ikke betale for noget for at have været på kursus hos mig. Se på SIVP.dk/XYZ for at tilmelde dig en gratis måned med det samme. Vi ses!